Good evening, chairpersons and all of you. So I'll be looking at this very common, some of the common problems which we encounter when it comes to pericardium. First, a brief look at the anatomy. It's a very brief one. So just to sort of remind ourselves as to what exactly pericardium is. It's an avascular structure. It's a fibrous sac surrounding the heart. It's got two layers. The inner serosal, which is lined by the mesothelial cells, and then you have the outer fibrous layer, the fibrous tissue is there. Now the serosal layer itself has got two layers, the visceral and the parietal layers, and this has got a potential space between the two. And this is the one which has the pericardial effusion, and this anywhere from 15 to 50 ml is what is in routinely normal people seen, and most of the times it is concentrated at the atrioventricular and the interventricular grooves. And this is usually transudate, the fluid, and the normal pericardial thickness by echo, because the resolution is not great, is just somewhere around 4 to 5 millimeters. So anything more than 5 millimeters, we say it is thickened. But actual thickness on the specimen is, even by MRI, is around 2 millimeters. And you also have to keep in mind there are two sinuses, the transverse and the oblique. So this is just a brief overview of the anatomy. Now coming to the pathologies themselves, so you have it's again a very broad one, so there are many ways of looking at the types of diseases, the pathologies. So you have pericarditis, and the common ones are the acute and chronic, and then there is the effusion which is there, and then the tamponade, which is the other extreme of it, and masses, the tumors and cysts, and then the absence of pericardium. So where are we in terms of as far as the imaging is concerned, as far as echo is concerned? So when it comes to the technical aspects, transthoracic echo performs fairly well in terms of availability, cost, and the way it sort of provides results in terms of its safety. But when it comes to the actual imaging, it is sort of limited, so it can sort of look at effusion, and to some extent it can sort of look at the layers, but it's good at, in terms of pericardiocentesis, to guide it, so it is an excellent tool. When it comes to the morphology, sort of somewhere in the middle, and then looking at the function, it scores very well. But in all other respects, CT and MRIs scores well, so this is where it is. When it comes to actual sort of the recommendation, so it comes as 1C here, and this is the transthoracic. Now let's take the first pathology. So you have the pericarditis, so this is the definition. So the acute ones where the duration is less than 4 to 6 weeks, and then you have the incessant, where that is without remission, and this is lasting for more than 4 to 6 weeks. And then you have the recurrent, so they have a symptom-free interval, and then the arrival new signs and symptoms comes after that. And then the chronic, which lasts for more than 3 months. So this is the various, these are various types of pericarditis. So what do we sort of see in terms of the actual sort of how do we sort of come to the diagnosis? So it's a little more detailed as far as the criteria is concerned. So there is the symptom here, chest pain, and then the auscultation rub, and the ECG ST elevation, and then echo comes here with effusion. So this is the only area where it sort of provides sort of real conclusive sort of information. And then you have the inflammatory markers, and then you have the other imaging modalities. Now when it comes to the others, it's more or less the same here. So this is from the ESC guidelines. Now the echo findings, so it can be normal. So there can be pericarditis, and you can get a normal picture as far as echo is concerned. And there can be pericardial effusion. So this can also move towards tamponade physiology, and then it can also sort of result in constrictive physiology also. So this is the spectrum of what one can find, anywhere from normal to constrictive physiology. And in addition to that, you can have the thickening of the pericardium in terms of how it is, and it's very sort of shiny. And then you have the fibrinous strands, you might see them occasionally. And then when there is myopericarditis, you can see wall motion abnormalities. And in the recurrent, it is more or less the same. Now this is an example of acute pericarditis, so a symptomatic patient with the investigations positive. So you can see that there is some amount of effusion here, and possibly there is some amount of myocarditis here because there's some amount of wall motion abnormality. So here again, the pericarditis, you have isolated pericarditis, you have the isolated myocarditis, and then pericarditis causing myocarditis or myocarditis causing pericarditis. These are the sort of various types that can happen here. Now, the recurrent pericarditis is an example of a patient who was doing well and came back some months later, and this is again, you're looking at an effusion here and some strands here. So this is an example of recurrent pericarditis with positive findings. Then you have the other various types. So in view of limited time, I'm just sort of briefly dwell on just a few points. So you can have the various etiologies which can land up here. So you have acute MI, which is the one which we commonly face. So here just again a few numbers. 33% may develop pericardial effusion, and it can either be localized, as you can see, or it can be diffuse circumference, as you can see here. And then the other important thing is whenever an effusion is seen in a MI, so especially the fatal MIs, you have to be, it has been shown that it has about almost 40% prevalence over there. And then you have the other etiologies, the viral, bacterial, and tuberculous. This is what we face most often. And then, of course, the neoplastic and the post-cardiac surgery over here. Now, moving on to chronic constrictive pericarditis. So this is the real sort of area where echo really provides a lot of information, and this we should be sort of conversant. So just again a few points. It's a lot of postulations, a lot of theories are there in terms of how the constriction happens. So, but remember, it is just the inflammation and the edema. So this is the sort of basic sort of substrate, and this is the one which makes the pericardium stiff and that decreases the compliance. And then you have this sort of phases which somebody has suggested. So you have an initial phase where there's effusion, there's going to be active inflammation at this time, and then it sort of moves into the pericardial effusion starts to reduce, and then the constriction starts to happen here. And then the third phase is when it normalizes, so you have this transient constrictive pericarditis where it spontaneously or with treatment, it goes away. Then there is another way of looking at it. So you have the fibroelastic form where you see it in the acute and subacute, where there is, or there might be even mild constriction. And you have the extreme where you have the elastics being replaced by the calcium here. So this is the one which we see in chronic severe constrictive pericarditis. Then just look at the various sort of findings in constrictive pericarditis. So the most classic one, the most important one which we must focus is one in the parasternal long axis, reduces sweep speed, and you have to look for this variation. So this is the septal shift. So this is respirophasic. So with every inspiration, the septum comes towards the LV, and then with expiration, it goes back. So it keeps going back and forth. So this is the important one. Then a brief, again, this ventricular interdependence, which we sort of discussed quite a lot. So this again is a comparison of the normal one, and then you have the constriction here. So it is one big chamber here, so there's no way the ventricle on either side can expand. So it is the septum which has to sort of respond to the filling, and this is how the septum moves back and forth as the filling happens on the right side and then again on the left side. So this again is a still image showing how it happens. So during inspiration, the septum moves and it expands and allows the filling. And then afterwards, what happens is during expiration, the left ventricle enlarges and the septum moves towards the right side. So this is just a brief way of trying to give the explanation to the previous image on M mode. Then you have these less sort of important ones. So you have the septal shudder, which occurs in beat to beat. You have these small sort of inward motions towards the left ventricle and then going back. And then the flattening, which may or may not be there. This is a picture of how one can even look at it from the 2D. So this is the septal shudder and also the septal shift. If you look at it closely, not enough sort of beats, but you can still make out there is some amount of shift that is happening. So just a quick look at this and you know that you're spot on with constriction. Then there may or may not be pericardial thickening. So this again, you can reduce the gain and you can get the pericardium prominent like this. And the other one which we are very familiar is the variations in respiration. So typically in constriction, the E is always more than the A. There is a short deceleration time, and the respiratory variation is objectively measured by looking at the E velocity from inspiration minus expiration divided by inspiration. So that's how we get the percentage here. So this again is a very important point here, and the data shows that if the expiratory, the mitral, the respiratory variation, even if it is more than 15%, it is quite accurate in terms of coming to a conclusion. Then looking at tissue Doppler. So this is another important parameter. Any E prime velocity, typically it is going to be more than 8 to 9 centimeters. So this again is another important parameter. Then you have the tissue Doppler using it both on either side. So you have the septal and then the lateral one. So you have the reversal here. So you see that typically the lateral velocities in a normal person is always going to be more lesser than the septum, and now it is reversed here. So this is the annulus reversus, and this is a more objective way of looking at it, dividing the medial E prime and lateral E prime, and you get this number here. So this again is a very important parameter in your sort of coming to conclusion here. And then you have this annular paradoxes, even though they have high LV filling pressures, because of this E prime which is increased, so the E by E prime will be normal. So this again is one more area. Then the other last important point is the hepatic vein wear sampling. So you can see that the exaggerated diastolic flow reversal. So this is typically during expiration. So you can see that with every sort of respiratory variation, you see this prominent one. So this is again another one. Again, an objective way of looking at it. You can measure both the expiratory, the forward flow as well as the backward flow, and then you get this number. So that's an objective way of looking at it. And then this IVC plethora, again, we are familiar with. So you have these hepatic veins and then the IVC dilated. And then how does strain help? So you have the strain, circumferential strain is going to be decreased, and then you have the longitudinal strain which is going to be retained here. So here again it's a little bit of a compensatory one as far as the GLS is concerned. You see that the lateral wall strain is less, and then the septal strain is normal or increased. And again you see on the curves here, so this is where it is increased and this is where it is decreased. So there is a term which has been suggested, not widely used, but this is known supposedly the strain reverses. So if I put everything into perspective, so this is how it looks like. You'll see that ventricular septal shift is right on top, and this is where the focus should be. And you can see that when you use these combinations, ventricular septal shift is always going to be part of it. And then you have the mitral E velocity, and then the medial E prime velocity, the lateral, then you have the annulus reversus here, and then the hepatic vein. So this is a sensitivity here in terms of how it sort of goes down here. And when you have these combinations, you can see that when you combine this 1 and 3, the specificity and the positive predictive value goes up. And moment you sort of mix all these things, the specificity and the positive predictive value increases. And this is how it should be. So you should sort of combine it and look at it. So these are sort of classic images, very easy, but in real life, you know that there sometimes some of them may not be seen, and that's when we sort of fall back on additional imaging modalities. And then looking at another unusual case, so this is a young male who came with typical features of constriction on clinical presentation, and not so, these are sort of recorded from the phone because of some technical issues. Again, all the images show that there is, the septum is, there's a septal shift, there's a septal shudder, biatrial enlargement is there. And then you have these tissue Doppler velocities increased, and the cath also confirmed that this patient had constriction. And this patient went for surgery, and there was a bit of a problem on table because they really sort of initially the first surgeon couldn't really identify where was the sort of constriction. And then afterwards they looked at it closely, and they found that the visceral layer was the one which was the culprit, and this had stuck to the myocardium here, and they had a very difficult time trying to sort of release the muscle over there. So this is the constrictive pericarditis because of with the visceral layer. So this is the epicarditis as it is called here. So this again has been quoted here. So here again, one is unable to strip it, so they sort of make incisions. This is from a presentation on the journal. So, but in our patient, they just sort of tried to strip away a little bit, and they were successful to some extent. A brief look at effusive constrictive pericarditis. This is another entity. So this combines features of tamponade, and this happens usually in the presence of acute pericardial effusion, and this is in combination with the chronic constrictive pericarditis. So here, even after successful pericardiocentesis because of the tamponade, the hemodynamics, especially the right atrial pressure, does not normalize, and that's when the alertness has to be there. That means that there is the features of constriction are going to be there, and this is the effusive constrictive pericarditis. So there is again a theory of postulations, or is it a wider spectrum, or is it a transitional state? So this is, but this entity is very well known, and one should combine, one should look at tamponade which has been tapped, and the constriction doesn't go away. So these are the findings. So you can have pericardial effusion, organized material, fibrous strands, thickening of the pericardium, loculated diffusion, and then most importantly, you have these tamponade findings, and also the post-cardiocentesis, you find the features constriction. Now coming to pericardial effusion, so pericardial effusion assessment, again a quick sort of go through. So typically we want to see where the effusion is, so whether it is circumferential, localized, or is it loculated, and what exactly is there within the effusion, and then are there any features of tamponade. So this is how your assessment is going to be for effusion. So how do we look at effusion? So it is classified as trivial, so only when you see it in systole, so this is typically normal when you see it, and then small effusions less than 10 millimeters, moderate till 20 millimeters, and this again approximately about 500 ml, and anything more than 20 millimeters that is large, and beyond 25 millimeters massive effusion, and the amount usually for large effusion somewhere around approximately 700 ml. And these are some examples. So again, tuberculous, you can see that this is something which we see quite often. And again, it causes hypothyroid is another one which we see quite frequently, and of course all the other causes of pericarditis which I mentioned earlier. And tamponade, how do we identify this? So remember that even small effusions can cause tamponade. It is the rate of accumulation that matters, not the amount. And the basic sort of approach is to look at the chamber collapse. So typically it starts with the RA systolic and then the RV diastolic, and this is in the expiratory phase. And then very late, with massive effusions, you get to see the LALV, which is very unusual. And the LA collapse, whenever we see it, is most often due to loculated effusions. And what we also have to keep in mind is there will be some variability where we sort of may miss it when we have a high RVDP, pulmonary hypertension, patient is on positive pressure ventilation, and when there is severe LV failure. And also when hypovolemia, we'll have a very small RV which will be collapsing, so this is again something we have to be careful. And high IVC plethora, these are all features of just like constriction, so these are the findings. So again, the pulsus paradoxus, as we all know how to get it, so we should be correlated, and then you have this inspiration, expiration, and this is how, again, similar to constrictions. The only thing is that here the effusion is playing the constriction role, where earlier it was the pericardium, thick pericardium was the one which was causing the restriction of the movement of the ventricles. So these are some examples of where we can see them. So post-valve surgery, so here you can see that the electrical alternance will be visualized in this, a swinging heart, and then you can see the indentation here. So this is where the RV sort of diastolic collapse is happening. And subcostal is another good view to look at the effusion and also to look at the contour which is lost here. So you can see that it is indenting where there is a diastolic collapse. And the respiratory variation typically just like constriction, and then you have the IVC plethora. And then another example of the post-op, especially the cardiac surgeries, where you have these sudden hemodynamic changes or a HP dropping, and then you get to see these effusions which have collected. So this is one example where there is a small hematoma there. Another example of where again a collection has happened and has caused a hemodynamic compromise here. So this is post-cardiac surgery, and these are the examples for that. And again, what is the role of T? Once in a while, we'll be sort of looking at T also to provide some answers. T is sort of is a good one to look at the thickness of the pericardium. Apart from that, this is one example. Patient had a road traffic accident and had a hemodynamic compromise. He had tamponade, and also this is the deep transgastric, where you can see that there is these are the small sort of multiple clots over there. There was bleeding within the pericardial space. So the role of T, especially with road traffic accidents, when you don't have a good chest access. So this is just how to look at the tamponade. So you look at the pericardial effusion, and then the hemodynamic changes take place, and then you have the ECG, the echo changes which happens, and then finally the clinical tamponade. So this is how one has to sort of look at tamponade. So it has to be from the clinical perspective, most importantly. So just a summary of how we look at it. So you have normal, you have the constriction here, and then you have the tamponade, more or less similar to each other. And these are the various ways of looking at restriction, constriction, and tamponade, and looking at respiratory variation, looking at chambers here, looking at pericardial changes, and use of tissue Doppler and the restrictive filling here, and then looking at PA pressures. So the constriction will have variations. The atria will be dilated, while in tamponade there will be compression of the chambers, and then you have the thickening, and then the the PASP will be more in restrictions. So these are again various points how to look at it. So just the last few slides, I'm almost coming to the end. So pericardial masses, a quick look. So pericardial mass, primarily very unusual to see pericardial masses. So the primary tumors are very uncommon and very rare, so to say. So it can again be malignant and benign. So malignant mesothelioma is the one which we all know. So you can have a thickened pericardium, you can have hemorrhagic PE, it can also develop into constriction. Then you have these other sarcoma, lymphoma, also teratoma, which can occur. Benign lipoma, hemangioma examples. And we often, compared to the primary, we often see more of metastasis. And where do they come from, the primary tumors? So from the lung, breast, melanoma, lymphoma, mediastinal malignancies. And here you can see thickening will be there, small nodules if you look very closely, and then you will have a very significant effusion, disproportionately more. And the pericardial cyst is another type of mass. So this is again the various etiologies are there: congenital, inflammatory, traumatic, and post-cardiac surgery. And where do you see most often? On the right side of the right CP angle, and then the left CP angle, and then it can be seen elsewhere also. It can be unilocular, multilocular, and you have this the way of characterization where you have this echo-filled, the fluid-filled space with a clear distinction from the cardiac chambers, and that's how it is. And you have these differential diagnosis. Various other entities can cause the bronchials, and even the pleural cyst can sort of cause confusion here. And this is extremely rare diverticulum. So it looks like a cyst where there is an outpoaching of the pericardial sac, and then you have the herniation occurring through this. And this part of the heart which sort of herniates communicates and with the pericardial sac. This is through the defect in the pericardium. So this is the description there. And it can be congenital or it can be acquired. And the last one is the absent pericardium. So it can be either partial, it can be complete, and there's a small subgroup. So this is where the foramen type of defect happens, and usually seen on the left side of the heart, but can be seen anywhere. When there's complete defect, no clinical significance, but when there's foramen type, you can have these herniations, and that is where the problem happens. And also look for any associated abnormalities like ASDPD and bicuspid. So echo findings, you have a very exaggerated cardiac motion, especially the posterior wall, and then the apical motion also, and then we have this very large sort of RV because the entire cardiac structure shifts to the left, and then you can have the compressed atria, and then many times you'll have apical views because the axis would have shifted, so you'll have to look at it from the axilla. And then there are these terms, pendulum arch, and then you have this teardrop sort of shape where you have the tapering sort of atria and then the large left ventricle. So this is how one can look at pericardial pathology. So there are, this is the table one can look at it. And then how does echo feature? It is a first-line imaging tool, and we should utilize it as much as possible. But we should also be aware that it has got limitations, and it can, in some pathologies, it may not be diagnostic or it may not be useful. But in some pathologies, it can be very useful, and it is very crucial in pericardiocentesis. Thank you.
Hello. Dr. Govind, I have a question for you. Post-cardiac surgery, how much of pericardial fluid is, right, you just examine them, how much of it is okay to send the patient back home, and how often will you recall these patients for follow-up? Sometimes you also see clots which are, and they will definitely lyse and there will be a bigger effusion later. So what do you do about the management? How often?
First and foremost is there are, if you look at it in a practical way, the first thing is like whether there's any chamber compression. That's the first thing you want to know. And secondly, you're also going to sort of observe the patient. Maybe the patient is having a slow accumulation, but at some point of time it sort of slows down and the patient is stable, and the surgeon is not keen to sort of really do anything, and it's sort of a wait and watch. So at that point, when the patient is stable, and then if you sort of keep monitoring, if the effusion is not increasing, you just sort of leave them alone. But if it's a large effusion, definitely more than sort of 15 to 20, and there's a likelihood of rapid collection, or if there is any sort of even a hint of chamber compression, I think that's when the surgeon would be sort of more comfortable. Otherwise, they'll always be worrying about what's going to happen next.
Another thing, like after surgical excision of pericardium in constrictive pericarditis, most of the echo features will still remain, like enlarged LA and IVC also. Sometimes it's quite dilated and the septal shudder doesn't go away. So how do you assess whether this is a successful surgery or not?
One is over a period of time, the myocardium also sort of improves. The other way of looking at it is just looking at the strain itself. If you look at the strain and if you can see an improvement in the lateral wall, you know that the tethering is gone and there is improvement in that. And then, of course, the other signs will also start to come down. So one can look at the traditional sort of points as well as looking at the strain itself and to see how the myocardium is improved and the tethering also. It gives you an impression.
Thank you. It's a great presentation. I think the other answer of this question could be that even after the surgical correction of chronic constrictive pericarditis, there is not complete reversal of hemodynamics. It still remains. So therefore, the changes will be there anyway, because the echocardiographic changes indicate the hemodynamics of chronic constrictive pericarditis.
Very,
so
very
taking
true.
some quick questions that you did mention about the respiratophasic septal shift in acute conditions, how it behaves in presence of complete left bundle branch block.
The left bundle branch block is more of a beat-to-beat variation, while when we talk about the septal shift, it is more of a respirophasic. So it goes with respiration. So that
it remains same.
Yeah, while the left bundle branch block and the septal shudder is more beat-to-beat.
The other quick question is that, you know, these days even in echocardiography advancement, like with tissue Doppler imaging, could you ascertain the pathology, pericardial pathology like masses and even inflammatory conditions of pericardium? Is there any specific description by tissue Doppler technology of the pericardium?
Tissue Doppler does not provide any diagnostic, in terms of what is the etiology, so definitely not. You can only look at the appearance of the pericardium, its thickness. Again, that is very sort of non-specific. To some extent, there has been literature data where they've done some studies, and that's also published in terms of how tuberculous effusion looks like. So where you have more the frond-like appearance, and then there's loculation. And that's how a typical tuberculosis. And then you also, if you look at it very closely, the thickening of the exudates will settle on the pericardial layer, and then it will look a little more thicker. So those are the ones as far as tuberculous effusion is concerned. But when it comes to tissue Doppler, no, it is just to look at the hemodynamics which you want to sort of establish.
Right. And finally, all the sort of kind of imaging findings are in relation to transthoracic echocardiogram. But nowadays, you did mention about the transesophageal in one of those cases of traumatic road traffic accident. But is there any different description by another echocardiographic imaging technology like transesophageal echo, or even intracardiac echocardiogram, as we are using most often in some conditions?
Intracardiac, I really don't know. I'm not sure about it. But transesophageal, when there is no availability of the transthoracic, or for some reason transthoracic cannot be done, you'll more or less find the same findings as long as you follow the Doppler sort of approach.
Especially first post-op day, I think a TE is a better option because you can hardly see
I'm
anything.
talking in general, like all those criteria.
There is no sort of real separation in terms of how it behaves. It's more or less the same findings as long as you do it correctly.
Thank you. Thank you very much.